The first speaker of the session, we have Dr. Swaraj Bhattacharjee. For ISOC purpose, he needs no introduction. He is from Assam. He is the General Secretary of East India Zonal Ophthalmic Congress. And he'll be talking on erratic, unpredictable people, puzzle out of the situation. So over to you, Dr. Swaraj.
So good morning, everybody. My topic is erratic, unpredictable people puzzling out of the riddles. No financial interest, of course. The erratic behavior of the iris may be in the form of small pupil, iris prolapse, intraoperative floppy iris syndrome, reverse pupillary block, and iris lens diaphragm retropulsion syndrome.
1 second. Can we call upon our president-elect of ISOC? Doctor, please come to the dais. Jayanto Barua, sir.
The small pupil, how small? It may be 4 millimeter or less. 1.4% of all cases comes to this category. All steps of surgery becomes difficult. Now a small pupil, it may be an elastic or it may be rigid. Now, how to find the difference between the elastic pupil and the rigid pupil? See, this is an stretchable elastic pupil as if we see in case of IFS, whereas a rigid or fibrous pupil, which may be tearable or stretchable.
So we have Dr. Abhijit Ghosh also. Please take the chair, sir. Good morning and welcome.
Can I move the timer a little bit on the other side? Timer थोड़ा नीचे कर दिया ना? Yes.
Can I sit there? It's too cold here. Sorry, hi. Sorry, hi.
Yeah, it's coming now. Okay.
Sir, I wanted to acknowledge Dr. Subhashis. Sir, I wanted to acknowledge Dr. Subhashis Nag also by calling him out. That's for few minutes only, sir. And after that, I'll call.
I will continue the putting visco or BSS.
Please, Subhashis.
In case of elastic people, there is a temporary expansion, as for example in IFIS. In the rigid people, there is no expansion, as for example in pseudo exfoliation. Now the management includes the preoperative NSAID drugs, intracameral adrenaline, viscodilatation, multiple sphincterotomies, and synecholysis, whereas iris management is done by iris retractor and the iris expander. The iris prolapse more likely to go out of the incision in cases where there is a lack of tone, as seen in the intraoperative floppy iris syndrome, an inadequately dilated pupil, a poorly constructed clear corneal incision, and a shallow anterior chamber. However, the reason is always a pressure gradient. Anytime the pressure behind the iris is more than the pressure in front of it, the iris will tend to prolapse out, and the treatment is always the same: neutralize the pressure gradient. And then the iris will return to its natural condition. Now, what is IFIS, intraoperative floppy iris syndrome? This was identified in 2004 and published in April 2005 by Dr. David Chang and John Campbell. Is specially associated with tamsulosin, the most commonly used drug for BPH, but has been reported to occur with other similar drugs too. And there is a tendency for the poor pupil dilatation. In addition, it has a ballowing of the flaccid iris trauma, progressive intraoperative pupil constriction, and propensity for the iris prolapse towards the phaco and the side port incision. The most commonly seen complications are iris trauma, posterior capsular tear, and vitreous loss. Now, why the Flomax? It relaxes the smooth muscles of the bladder, which is a mechanism of action for treating BPH. It acts on the iris dilator as well, by specifically targeting the alpha-1 receptor. The blockade of this receptor makes the conventional dilator drops ineffective. The floppy iris, the predisposing conditions are alpha-1 receptor antagonists like tamsulosin, terazosin, alphazosin, angiotensin antagonist, ETR antagonist, and nitrates, whereas in systemic diseases like chronic heart failure, diabetes, and systemic hypertension, No amount of history taking can prevent the surprise, but kept us alert and vigilant during the procedure. The current concept, there is an inhibition of the iris dilator smooth muscle contraction leading to meiosis. There is a degeneration of the long-term dilator smooth muscle causing floppiness, and there is a strong affinity for some systemic medication like psychotropic drugs which binds to the iris pigment granules. It's important to know that even with the pupil diameter less than 7 millimeter, even with no history of intake of alpha-1 receptor blocker, IFS can happen. It can even happen after 1 year of stoppage, even after 3 to 4 days of starting of the therapy, and stopping doesn't help always. Even it may cause some hindrance in the form of urinary retention with the case of preoperative atropine use. The mechanical dilatation of the pupil is done by the pupil stretching, not effective in IFS as it is an elastic pupil, and controlled stretching before expanding as in case of a rigid pupil. Iris retractor and pupil expansion rings. In all these cases, it prevents it from constricting and restrain the iris from prolapsing. Now, I like to share a case where there is a 65-year-old patient, moderately dilated pupil, using tamsulosin for BPH. In this case, we are anticipating IFIS. In this situation, what we are doing, we are putting the iris hook, and taking extreme care, giving a long corneal tunnel. In all cases, this type of the trypan blue must be used. It's a pretty hard case, but very well managed. After putting the IOL, the iris hooks are carried out very comfortably. Then this is another case, 62 years BHP patient using medication with add-on pseudo exfoliation. Here in this case also, in the same type, we are doing paracentesis, putting the different number of iris hooks. Depending on the situation, 4 to 5, we can put it very comfortably, making the pupil in a very comfortable position, and rexis tunnel and so on. The iris hooks pearls are, while doing paracentesis, clear corneal, posteriorly directed, and iris hook introduction. I'm not going in all details of it. Now we'll come to the pupil expansion ring. Results are comparable with the iris retractor like Milligan ring. The surgeon must be trained to use the ring. Successful placement requires a narrow range of pupillary size and difficult to place if the anterior chamber is very shallow after the capsulotomy and hydrodissection. Now the present choice is the BHAX ring, where I'm just showing an example, 60 years old male using tamsulosin. We are anticipating IFIS in this case. Same way we are continuing after blue, then we are putting a BHAX expander, putting visco, and then the device is snugged into the anterior chamber with a 23 gauge forceps. The flanges are inserted below the iris, 3 flanges with the holes. And we continue with the surgery. After the IOL insertion, these are very comfortably removed out of the anterior chamber. I like to give an example of a small pupil where in this case what we are doing, we are trying to use all the maneuvers in the form of viscodilatation, then with the synecholysis, but it's not well helping us out. Then we are using a BHAX ring. Here we are using a BHAX forceps, specifically designed by one of our ISAC member, Dr. Chauvin. Every one of us know him. And this similar way, the flanges with the holes are introduced one by one, and we end up with a beautiful hexagonal pupil. Next is the reverse pupillary block, the iris retropulsion syndrome, where this is in situation where the pushing the BSS with the cannula, the pupillary edge compresses against the lens, and there is a development of compartmental syndrome. The anterior chamber pressure increases, whereby the lens is pushed posteriorly. The situation where you can anticipate are high myope, post-vitrectomized eyes, and the young patient undergoing surgery. The pseudophakic reverse pupillary block may also occur in the patient with the pupillary optic capture in sulcus fixated IOL. Their clinical scenario being posterior displacement of the lens iris diaphragm, marked deepening of the anterior chamber, posterior iris bowing, pupil dilatation, and significant patient discomfort. And when it occurs 360 degree, we will call it lens iris diaphragm retropulsion syndrome. The reverse pupillary block are seen while doing hydrodissection during introduction of the irrigation ports and more with the use of viscoelastic Hilon 5, etc. Here, in this situation, this is a high myopic cases where we can see while putting the hydrodissection, see the pupil is dilated. Once you touch it, the pupil return back to its normal position. And what are the take-home points? The iris may behave erratically at any point of surgery, but with adequate pre- and perioperative measures, it helps to manage the situation comfortably. Proper armamentarium must have backup IOL, iris expander, and CTR if the situation demands. And thank you for a patient hearing.
Thank you, Dr. Swaraj, for a very nice presentation. Just one quick question about the floppy iris syndrome. That means the take-home message is what you said, that history taking is very important, isn't it?
Yes.
And even if you take a history, you have a tamsulosin taking patient, stopping the tamsulosin is not going to help in the floppy iris syndrome. So you have to be prepared according to the history as to what can happen. So do you think you should put in the iris expanders or the pupil retractors in all cases of floppy iris syndrome?
In cases where once you put the visco, if you see the floppiness of the iris, a word of caution immediately comes up. Secondly, we should also, I have not added this, I have missed this line. We should do in a low fluidics. That is also very important. In the newer machines, they have been given a very nice in centurion, and all low fluidics very comfortably can be done.
And second point, what I feel is that the pump of the machine is probably also important in these kind of situations. You have a Venturi pump in which you have to stay at the center. All the pieces and everything comes to the center. You don't have to go to the periphery. Especially for these kind of cases, a Venturi pump is probably going to give you more comfort. This is what I have felt. So, can we move on to the second topic? Anybody, any panel, anybody, anyone asked to ask anybody?
Do you have any
Just
of using pediatric adrenaline?
In the small people, always we give first viscodilation, followed by, before viscodilation also, we use it.
Because we also encounter so many such cases.
Yeah.
With my experiences, many a times like I can get away with adrenaline and viscodilation.
Intracameral adrenaline is more than enough in few of the cases. Here I am tried to show you the cases where we have used the expanders and all other things.
I fully agree with you. Adrenaline do help a lot in tackling such cases. And I principally use, when I have some doubt, I always use adrenaline before surgery. And secondly, low parameters are there. And thirdly, make all the side ports very, very small, just enough for instruments to manipulate your instruments. And fourthly, use little higher IOP so that it presses the head. Thank you.
so we go with the second presentation.
Nothing.
Intracameral doesn't make.
Doesn't